So again, my job's slightly complicated or complex, not necessarily complicated, but I do public health emergency preparedness for all of Hampden County. So the main priority of my work is public health emergency preparedness, which is like emergency points of dispensing. So if there's a mass vaccinations or stuff like that. In coordination with that, we support the Medical Reserve Corps. So again, I'm the director of the 6 regional units of Hampden County. Outside of that, I've been a firefighter paramedic, and I still am for the past almost 16 years now, and I'm up in Montague Center. So I've experienced a lot of this on both sides of the house, and I'm hoping to bring some of my tidbits of information in and teach you. So thank you very much for coming. So just to go through the course, we're going to be, these are the objectives. We're going to be introduction to naloxone, recognizing signs and symptoms of an overdose, and then review NarCan administration. So naloxone versus NarCan, what's the difference? I may say either one back and forth, so as not to confuse anybody, but basically naloxone hydrochloride is a drug generic name, and NarCan is a brand name. So you have different medications, generic and brand name goes for lots of medications. So you will see both names mentioned, but the reality is they're essentially the same thing. What is it used for? So NarCan or naloxone is actually used to reverse respiratory depression for opioid overdoses. It's not effective against any other medications, essentially. The way it's designed to work, it just doesn't work for respiratory depression for other reasons besides opioids. These are some of the common opioids that you're going to see out in the field or just in general in public. You're looking at morphine, heroin, oxycodone, hydrocodone, fentanyl, methadone, and I can never say that. I can't, sorry. I'm not going to butcher that one. Buprenorphine, thank you. So a lot of these are medications that you see for common use. Heroin obviously doesn't have a prescriptive value essentially, but it tends to be derived from morphine and on the illegal side. But the rest are common medications that you see every day. They're prescribed. We use them on the ambulance. They're used every day in the ER. It's a very common thing. So just to kind of get to the difference of some of the opioids you're going to hear about, I'm sure you've heard in the paper, fentanyl, carfentanil, what's the difference? Carfentanil is extremely strong. So you're looking at 10,000 times stronger than morphine. So morphine's pretty strong. A lot of people respond pretty well to it. Carfentanil is essentially an elephant tranquilizer. That's what its primary use is for veterinary medicine. Fentanyl is, again, common for humans. We use it all the time. Pain relief, broken bones, any kind of sedation. So, you're looking at potency. And the hard part, what you see on the streets is, if you go to a drug dealer, you might be buying pills. Do you know what's in that pill? Maybe, maybe not. You can go on the internet and actually get pill presses and actually make your own pills, and that's what some people are doing, and you have no idea what's in it. If you're abusing other substances, white powder, you have no idea what's in there. You're not going to CVS to pick this stuff up. You could be getting baking soda, you could be getting heroin, you could be getting trace of carfentanil in there, fentanyl, whatever it is. It's very hard to see what's in there. So you're not going to CVS or Walgreens and picking up something you don't know exactly what's in there through FDA approval. It's just somebody mixing stuff up. So I'll play devil's advocate and be the bad guy. If I'm looking at smuggling drugs into the country, which is easier to get a lot more in and a lot less noticeable with a lot more potency? Yeah. So that's why you start to see even the fentanyl is coming from China, and there's various synthetic copies and variations of that strain that aren't that much different, but still have essentially the relatively same effects as the banned substances. Or people are creative, and they like to do engineering. It's the best way to put it. So being a bad guy, I might get some fentanyl, carfentanil, whatever it is. Well, the problem is if I give this to somebody, that's a lethal dose. So I need to dilute that a lot more. So some people are very creative in the way they split stuff up. Some people don't realize it. You know, a lot of people go to the grocery store, look at the big box of cereal, and we're looking for volume. People don't want to get a little packet of one drop. They want value for their money. So if you were to actually mix the same amount of carfentanil and heroin, that's lethal to a lot of people really quickly. Some people understand that, some people don't. The mixing and the cutting agents tends to be thrown into a big container, mixed in some sort of way. It's kind of like getting a recipe from a family friend that's got a pinch of this, taste of that, drop of this, drop of that. You don't know what you're getting. So there's inconsistency between batches, and the reality is you don't know what's coming or what's going on. So kind of scary. Again, going back to pill use, substance misuse comes from a long history of those medications that are out there that people are prescribed and overprescribed and got hooked on. There's people with just tendencies towards certain objects or certain items. So it happens, what we've seen traditionally is a lot of people over the past 10, 20 years has gotten some of the synthetic medications. They're on it for a long time, their resistance builds up, they need something a little bit stronger, a little bit stronger, a little bit stronger, a little bit more. Then they reach that threshold and it's not enough. And sometimes providers are notorious for slashing them in half, taking them off their meds, and resetting them down to zero. Well, if your pain level is always here, and that medication you're taking brings it to here, and that doctor just slashed that med, and your pain level, or your pain tolerance is down here, but your pain's still here, you're not going anywhere. So you need to compensate for this. Unfortunately, the black market is good to get into some of those items, and things happen, and people get creative. So it's not just heroin, it's prescription use, and it's a variety of issues that people have that are worked on through various means. But it's kind of a slippery slope when you start losing that battle. So how does NarCan work? So essentially, skipping down a lot of A&P and really watering it down for you guys. As a medic, we had to learn a lot of it. Some of it's kind of cool, but to simplify it, essentially, your central nervous system, which controls your level of responsiveness, your breathing status, your heart rate, everything that really is the power, has receptors in your brain. So on your central nervous system, there's receptors. Opioids bind to this receptor. Basically, the more receptors that are blocked, the less drive you have. You're going to start getting sleepy. You're going to start slowing down your breathing. You're going to keep going down the slippery slope until you stop breathing. Eventually, your heart's just going to stop because there's no oxygen coming in. Your body's saying sleep really deep, and your body essentially gives up. So that's an overdose, kind of in a condensed form. What NarCan does is it basically comes in, if you think of it as you have your receptor, and you have your opioid that's bound to it. Basically what it does is comes out and smacks it off and binds to it. So the NarCan has a stronger affinity to the receptors than the opioid does. But the problem that some people realize and some people don't is it doesn't eat that opioid. It doesn't do anything to consume it. All it does is knocks it off, and then it wanders through your body. And eventually it's going to come back and go, what? Oh, this one's free. I'm going to go here. I'm going to go here. So depending on how much opioid you have, how strong it is, depends on how much NarCan you really get. On here, the typical receptor site, NarCan works for 30 to 90 minutes. 30 to 90 minutes, I would say, is kind of a high estimate. I've seen NarCan burn off in as little as 2 minutes. So when people give the first dose of NarCan, they think, well, you're good for a while. The reality is you might not be. Depending on your body, depending on your metabolism, depending on what's actually in the batch, depends on how much you took, depends how long of a history you have. There's lots of different dynamics to it, but the reality is 30 to 90 minutes could be as little as 2 minutes. Again, they're displaced, they're not destroyed. So they're not absorbed, they're just floating around. So eventually the NarCan's gonna wear off and then they come back to the receptor, and then the same process happens again and again. So process of an overdose we kind of touched on a little bit is the opioid overdose triad. So there's unconsciousness, reduced consciousness. So again, think of that. We're really tired, get home, turn the heat on, especially nowadays, when it's getting cold in the wintertime, and we start nodding off. That comfortable feeling. That's the first step in the long process up till death. So people are sleepy and just kind of acting lethargic, kind of tired. That's one of the first signs of reaching, or that's the first process of knowing that the opioid is actually binding to the receptor and starting that process. And what happens in medical prescriptions, usually initially, is you know your dose you're starting at, and it helps take some of the pain away from my leg. It kind of numbs everything down a little bit, makes everything happy, but it's not enough to knock you out to make you sleep or die. So that's kind of the first start. Pinpoint pupils. So opioids tend to give pinpoint pupils. That's a good telltale sign when you're looking at somebody trying to figure out what things are, why they're unconscious. Not always the case. Sometimes there's other factors that will vary that out, but pinpoint is fixed and very small. They won't respond to light typically, but again, that kind of depends on other factors as well. So it's a good guidance, but not a firm, hard fact. Respiratory depression. So as you're getting more tired, your respiratory drive starts slowing, and then eventually you go from breathing 14, 18 times a minute, depending on how fast, down to 2 or 3 a minute, down to 0. So you just kind of keep feathering down the more tired you get. If it's not treated, they're eventually going to stop breathing, and if they stop breathing, they're going to die. You can only last so long without breaths, and your heart dies, and then you die. Opioid overdose is a medical emergency and really needs to be treated. Signs and symptoms. These are some pictures I pulled off online, and I apologize for being graphic, but I think that people need to see the image of this. I found people personally in the car. Coming in my job, I've done this for a while. I've given NarCan for lots of years now. When I first started, I was giving NarCan 2 milligrams, 4 milligrams max. Nowadays, you're seeing treatments up to 10 milligrams or more. I've seen as high as 20 actually in a patient, because the medications are different. People are mixing things different. Things are stronger. I've dealt with pediatric patient that got into mom's drugs, legal drugs, prescription. I've gotten to pediatrics that have gotten into parents' illegal drugs. I've gotten the traditional somebody battling with substance misuse. And I've dealt with grandma with dementia who took too much back pain medicine, didn't know. The reality is, it doesn't matter who we're working on, this is good for everybody. And coming from the story, I've known people that have personally passed away from overdose and battle with substance misuse, so it's not easy. You see a lot of these things. So we always worry about, why are all these people laying down? And nowadays we kind of have to worry about other things in this world. So it's not just overdose, could be other factors of people doing crazy things in the world. But, this is what it looks like. This is what you see. Sometimes you see one person, sometimes you see a group of people. There's really no telltale sign. There's no, regardless of clothing of people, you can't make any assumptions of what these people are. They could be, I've seen people with significant authority that have issues, and they could be wearing shorts and find them in the park. And other people that just are having problems and just, the reality is we can't make assumptions about people. We need to treat them, and they look dead, because essentially that's what they're doing. They're dying. They are dead, so until proven otherwise, which is why we want to fix this. Again, sometimes it's very apparent to see the evidence or suspicion of opioid use. We tend to see people with needles hanging out of their arm. That's most likely what they were doing. Some of the opioids that they're injecting are actually that fast, where you actually find people with needle hanging out. Sometimes they're dropped next to them. Sometimes they're snorting it and doing other ways of taking taking the opioid. So the reality is you don't know what it is. One call I had was a car into a telephone pole at a large superstore, and got off the engine thinking it's somebody blowing donuts and having fun, because we've all done that. And get to the car and see mom and dad, or male and female, unresponsive in the parking lot in their car. They pulled in the parking lot, never put their car in park, popped in fentanyl patches, started chewing them, and went unresponsive and rolled into the light pole. Thank God they didn't put it in park, because somebody actually noticed the car hitting a pole and called, rather than them dying in the car quietly. The hard fact was there's two unrestrained children in the back seat. It's kind of hard to deal with. It's kind of frustrating. The reality is they're people, they're somebody's loved one. We address it accordingly and we take care of it. But this is a good picture of it. And again, this could be in a house, this could be with one person, two people in a car. If you ever come across the car scene, make sure it's in park, take the keys out and put them somewhere else, because there's been YouTube videos you see of they get NarCan, they wake up, they're not sure what's going on, and they take off. And it's not fun if you're under that tire and you get run over. Try explaining that to your family. So please try to be safe when you do this stuff. Again, these are going through the not breathing or respiratory depression. If they're, depending on where you catch them in that kind of tilting down of the respiratory, they might have enough of a drive that they're maintaining their airway. They might get sleepy and not maintain their airway. They might be not breathing, and then eventually they won't have a pulse. If they're breathing, they most likely have a pulse. Sometimes they have agonal respirations, which it seems like they're breathing, but they're not. So you want to kind of assess what's going on, but depending on where you catch them, they could either breathing kind of normal and just being a little tired to dead. Again, it's a sliding scale. Steps for care. Your safety comes first. You guys are number one. The last thing that we want to see as responders is a group of people that have been exposed to whatever, have been run over by somebody, especially when you start talking about the street or the parking lot. You might be rendering care and not paying attention to what's going on, and on the side of 91, somebody comes up and hits you. So try to be careful. Regardless of every emergency, as bystanders and even as responders, we're responsible for our safety. Nobody wants to make that call and say they didn't make it home, or have somebody knock on their door and say they didn't make it home because they're helping somebody out. So really take the time, see what's going on. So please, please, please be safe. There's some other scene factors that we're worried about also when we come up. There's a high probability that the substance you're coming across was injected. Probably not 99%, but you're talking about at least 50 to 60%, most likely injection. There's also other ways as well, but that's a different issue. So we're worried about sharps, we're worried about kneeling on a needle, getting stuck with whoever knows what, and other exposures. The other issue is, especially when you see the fentanyl, car fentanyl with the powder, is people want to walk up to a patient, and if they're covered in powder, and the first thing people want to do is, that is just aerosolized. You're now breathing in because you're excited and breathing. I really want to help somebody. And guess what? You're down too. So if you ever come across powder on their chest, stuff like that, no problem. If you have water, wet rag, just wet it down. The water will actually kind of not make it the biggest thing you're trying to stop is the product becoming aerosolized. You breathe it in. That's not a good day. So white powder, unknown. If they're down, that's a problem. Like, that should already be clear, like, something's wrong, I shouldn't be breathing this in. That comes for, regardless of what kind of hazmat you're dealing with. So, safety first. Call 911. 911 is there to help you. They're great people that are on the other end of the line. Dispatchers will walk you through stuff, help you. So if you forget everything I tell you today, they'll help you with this. That's what they're trained to do. With that call, make sure you know who you're calling and what dispatch center you're dealing with. So that way you know which resources you come across. If you're going to have somebody call 911, make sure you designate and point. Because what happens is people with their cell phones want to take a selfie with, hey, look what this guy did. So their phones are out, but sometimes they're not calling for help. Sometimes your cell phone may bounce to other states. You're on the line, am I getting Connecticut State Police? Am I getting Massachusetts State Police? Don't know. So there's times that does happen, so just be aware of that. Make sure you know what town you're in, what location. If you say, I'm at the Dunkin' Donuts, I think I'm in Springfield. How many Dunkin' Donuts are there? How many other towns have Dunkin' Donuts? So try to be aware of that. With that nice call, they will send help. It may take them a little bit to get there. Depends on the time of day, depends on what's going on. They, trust me, the only thing they want to do is come help. They're not taking their time, even though it seems like it. They drive fast and they try to help as fast as they can. You have law enforcement that shows up, you have fire, you have EMS. It could be a combination department where they do fire and EMS. It could be a private, so you could have multiple agencies dealing with this. They're going to come help you. They're a great resource to help you. This patient by yourself is very hard to manage. There's lots of complications that you're worried about. You're trying to help them best you can. And going into some of the other things we deal with, one of the things to be concerned about is combative patients, which we'll touch into later on. But these people are comfortable and happy. They had that after talking with somebody that was a user for a long time and having some of those discussions. Is basically like having a couple beers or a couple drinks and just kind of getting tired and then sitting by the fire and kind of falling asleep. The last thing they remember is that really happy, warm feeling, going to sleep. And the next thing you know is have a stranger standing over them going, wake up. At 2 in the morning, who wants me standing over their bed? Come on, no hands. Damn, one of these days I'm going to get it. But anyway, the reality with that is, there's a lot of paranoia there. Sometimes they wake up and they're just kind of sleepy. Other times they're really combative. So just be careful. Again, 911 coming early is going to help you, talk you through some of the stuff, and they'll be more resources to help you because the thing that they need is care. You're going to determine responsiveness, decrease responsiveness. So obviously, when calling 911, think about the scene. They're laying there. It doesn't look right. So if you're walking up to those 3 guys in the park, there's something wrong there. So there's decrease. People shouldn't be slumped over like that, so something's wrong. So you're going to check for responsiveness and see if they're awake. If they're not responsive, you're going to check for respiratory depression. So if I'm doing a sternum rub, which if everyone takes their knuckles, puts it to the center of their chest. I'll get the microwave out of the way. Center of your chest and push down your chest, that hurts. So if you're doing that to a patient and say, you okay? After you tap and shout, they're not awake, give them a sternum rub, see if they wake up. If they don't groan, that's a problem. That means they're past that. Sometimes you might get no, okay, that's better than nothing, but still not where they should be. If somebody's driving on your chest, you should be trying to fight them off. Anything less than that is not a good sign. So with respiratory depression, you're going to start rescue breathing and or CPR. This is if you don't have NarCan. Actually, technically, you should be starting CPR, but if you're suspecting an overdose right off the bat and you have NarCan available and you're by yourself, I would pull out NarCan, give it to them, and start CPR. Regardless of CPR started or not, in this one particular case with opioid overdose, the only thing that's going to save them is to knock that receptor clean and say, wake up. So you need to get that on board as quick as possible, and by getting that in there and started, means you can do it. If you have help, by all means, somebody starts CPR, I'm going to give NarCan, do whatever. If NarCan's not available, right to CPR. And on here I have a star next to the rescue breathing. So technically the rescue breathing is a critical step in bystander rescue because they're so respiratory distressed that they don't have enough drive to keep going. People don't know who they're coming across. It could be our loved one. It could be somebody else. Do you want to do mouth-to-mouth with a stranger? I say no. I would say that's probably a safe bet, and that's fine. Sometimes there's powder on their mouth. What did we talk about powder? Now I'm putting my lips. So opioids really bind to the mucous membrane. What's a mucous membrane that you're giving mouth-to-mouth? Oh, my mouth. So I'm exposing myself to that thing. So I would not personally recommend mouth-to-mouth at all. Use a barrier device or just do hands-only CPR. Hands only CPR. So again, we're going to tap, you okay? No response, sternum rub. And I want to see, I'm going to give NarCan. Expose their chest to see what's going on. And hands only CPR, for, in case you aren't familiar, is, you know, you got your sternum here. So you want the center of the chest, so right down the nose. Some people say nipple line, but obviously as we age and grow, things tend to move it a little bit. So center of the chest at the armpits. Put you right about the same location. Some people, again, use nipple line, some people use armpits. I kind of like the armpit because it's very easy to do. So center of the chest at the armpits, dominant hand down, and I'm just pressing. At least 100 a minute. So by doing this, you're actually moving air and supporting it. You can do CPR on somebody with a pulse without killing them, which is great. And if they're so unresponsive that they take your CPR and don't wake up and fight you, then they need it. I always joke and say, I always stop CPR after the first 3 ouches hurts. Ouches hurts, ouches hurts, ouches hurts. Stop. The reality is, we're at that fine line. We need to make sure they're getting air. We need to circulate some stuff. So that is a good default to get those breaths in without contaminating yourself, without a pocket mask. If you have a pocket mask, they're somewhat tricky to use. You can use it, yes. I would use it if I had a pocket mask. But on a stranger that I'm walking up to, I'm gonna do what's better for you, for both of us. Because if I get sick and collapse next to you, that does neither one of us any good. Again, administer the NarCan as soon as possible and encourage professional medical attention. A lot of things we see, especially with the general public getting NarCan and being out there, and I think it's a great program. I think it's a great initiative. Some people wake up and don't want to deal with the cops or don't want to deal with the firefighters because they're a pain in the butt and they don't like me. They offer a lot of different assistance. They don't just take you away in handcuffs. There's programs that come out and talk to you, and programs to support your other needs besides, you know, your emergency crisis now. So I've seen some people get NarCan and run away. Well, they just ran into the woods. And what do we talk about that timeline of how long does NarCan last? Anywhere from 2 minutes to 90 minutes. Maybe we'll see them in a couple days when the buzzards are flying around. So try to be supportive. Remember this, depending on the person, I mean, a lot of people, regardless of wherever they are or what they're doing, kind of embarrassed. Like, I was fine and I have a bunch of people standing there looking at me. Like, it's kind of an embarrassing thing. So treat them with respect, do the best you can, and really encourage that. Obviously, with 911 call and them coming, that's a great resource to tap into. Don't be afraid of them. They're great people to talk to. We've seen a lot of these things over and over, and I've seen people I've NarCan'd multiple times in one day, and go back and see, and I'll be back in 2 hours, but they sign the patient refusal, and that's their right to. Some people battle addiction and overdoses significantly through their life, and on overdose number 300, they see the light and they do a complete 180 and, you know, productive members of society and doing everything, and will change. I don't know. So there's sometimes no rhyme or reason. It is kind of frustrating sometimes when you see some of the things, but the reality is they're people, and we all battle with bad things. So really try to encourage that professional medical attention, because again, we're worried about the NarCan burning off, but we're also trying to get them out of that cycle of, you know, being in this condition, or at least supporting them in any way we can. Whether it's this time or 30 times from now, we're trying to get that taken care of and really help them out. So again, hands only CPR if there's no barrier device, get that NarCan on board and continue supporting them as best you can. After administering NarCan, so your first dose is going to go in. You may have respiratory drive come back up. To me, that's a good thing. I don't necessarily need somebody waking up and talking to me, but if they were starting to breathe on their own, I'm happy. With that, there's a high probability that when you give NarCan and they wake up, that they're going to vomit. As you start falling asleep, your stomach relaxes and all the good stuff mixes, and you start doing CPR, and there's a good chance you might get vomited on. So be aware, give it, and kind of watch. So if we started off with a respiratory rate of 2 a minute, that's not enough to sustain life. I give NarCan, I'm going to be watching them. I want to see their breaths start coming up, get a little stronger, a little bit more, a little bit more. And again, about 5 minutes is when I consider giving more. And I want to see that drive come up in something adequate. I want to not see them, going back to those pictures that we saw, these people look like the color of this. That's not normal. I want to see the pinking up of their skin. If they have dark skin, look at the mucous membranes, looking at their lips, stuff like that. Is it starting to look more normal? I want to see that drive come back up. I don't necessarily want to see them, hey, what's going on, and running away. Because when they're up and standing, they could be fighting you as well. So I want to see it come back up. And if I have more NarCan, I'm going to give more NarCan and just go from there. If you only have 1 dose, do what you can, and then be prepared that they could start going back the other way and start, the opioid is starting to bind to the receptors, and they start going back down that slippery slope of going towards death. So I'm going to start doing CPR. If there's no NarCan, that's fine. If you have it, that's great too. I mean, if you have it, use it. If you don't, then I'll be prepared with the CPR. If they start breathing normally, so if they're pinking up and things are going well, because we're worried about the vomiting, I want to put them in the recovery position. So lay them on the left side, support their head, put their knee, and just be prepared to take care of the airway. They might puke. We don't want to stick our fingers in somebody's mouth. You put your finger in my mouth, unless you're feeding me something sweet, you're probably going to get bit. So just kind of remember that. You can use their shirt, use something obviously clean, not dirty clothes, but if you have their shirt, you can kind of wipe their mouth and kind of clear out the airway so you're not aspirating that. And really watching the patient until the ambulance arrives. Again, they're getting there as fast as they can, but when you call, it takes forever, or at least it seems like it takes forever. Again, every 5 minutes is what you want to be doing, and you want to see improvement. If you're not seeing improvement, that's a sign to give more. And then give more if you need to. However much you have, however much it takes. I would love to say that 1 dose always works. Not typically. You're seeing 2, 3, 4 rounds of NarCan administered, and sometimes it's 1 or 2. So the key points to take away with this is, the naloxone effects may be shorter than the opioid taken. So the NarCan may burn off before the opioid is, really, the opioid stays in your system longer than the NarCan does. So when the NarCan wears off, the opioid comes back. Again, we just displaced it. We didn't absorb it. We didn't get rid of it. It just kicked off in the system and floating around your body for something else. Patients really require the further medical care. Again, there's support services, there's medical attention. These people could be having a whole wide array of issues, regardless of substance misuse or not. They could be having a heart attack, they could be having something else, a stroke, anything else. So it really should be followed up and provide some medical care. If you can remember what time you gave the NarCan, give it to the EMS. Like, give it 5 minutes ago. Obviously, your response time is relatively short, but sometimes it may not be. I gave NarCan at 6:42, and I gave it again at 6:45. Okay, so that way you kind of know how many rounds of NarCan we gave, what the timeline is. If you know of any other drugs were taken, that's a good thing. So I've seen some people that clean up the scene really well before they even call for help, which leaves that patient even more vulnerable and higher chance of death. Some people are willing to share, like, oh, I saw him drinking a whole bunch too, or maybe he did something else. Don't know, but if you can get any kind of information that helps us build a better story to figure out what's going on, we might be facing multiple drugs with polypharmacy. Again, find out how much was given, any other drugs taken, what the effect of the NarCan was. I gave him 4 milligrams of NarCan, and his respiratory rate went from 2 to 3. Okay, I gave him another 2, and it went up a little bit more. So it tells us a better story of we're dealing with something extremely strong, or we're going down the wrong path. We want to be making the patient improve when we're giving care. Any other interventions you did while doing this. So I had to do CPR for 5 minutes, and then he woke up, started coughing. That kind of storyline really helps responders provide the best patient care. Why it might not work. So it's not always effective. And again, going back to the way NarCan attacks the opioid, it might not be a opioid drug that they're on that put them unresponsive. They could have just been eating a sandwich, choked on a burger, and dropped right next to a syringe. That wasn't even theirs. Or maybe it was. Who knows? So there could be other reasons why they went into cardiac arrest. Inadequate dose of NarCan. So I only had 1 dose, and he probably required 2 or 3. Okay. Again, you're looking for improvement. You're not necessarily looking for a walking, talking patient, but you're looking for, I want they're improved more than they were a couple minutes ago. Mixture of multiple drugs taken. So again, sometimes you have drugs that are in your system. You start combining different drugs and unique things happen. Alcohol, it will not work on alcohol. It only works on opioids. And any other kind of medical conditions. So be prepared for secondary drug effects. One of my worst stories is I gave NarCan to a patient, and they woke up and were doing fine. Gave another round, or they're getting better, gave another round. And what I didn't know, and some people using drugs, street drugs, have no idea what they're taking. This patient actually had cocaine on board as well. So cocaine's an upper. Opioids are depressants. So he was depressed. And then when this was taken care of, cocaine shot up and actually put him into a heart attack. Which better? Dead or heart attack? Heart attack I can treat. Dead, it's a lot more work. It stunk and we took care of him, but the reality is there sometimes is some polypharmacy issues that develop that you have no control over. Don't feel bad, just be aware of it. And the other thing with that stimulant is you have no idea what else is on there. So if you get rid of that sleepiness drive and they're on some methamphetamine or something like that, you might want to get out of the scene, get out of the area, get some help there. So that's why it's important to call 911, get help, and go from there. So just be prepared for secondary drug effects. You know, people mixing stuff don't know, and you know, I want to clean this out of my, it's thinking of cleaning out your refrigerator. You always want to take out some stuff and maybe I'll just do leftover day. They do it the same thing when they're mixing, and there's a dirty table that they're, you know, making meth here, little heroin here and there, things get mixed, whatever. Things do happen outside of the person taking that substance control. Possible adverse reactions. I tend to see combativeness a lot. A lot of these symptoms you see, the watery eyes and nose is kind of okay. Rapid heart rate, again, for stimulant and stuff like that. We're worried about low blood pressure. You know, they're in a sleep. We're waking them up. We're standing over them. They're confused. I don't necessarily take the attack on me personally. I don't think it's going after necessarily a badge. I think it's more the confusion of somebody standing over them, like lighting their face, checking them out, like get out of my personal space. But again, combativeness is a sign that happens frequently. Vomiting should be up there. Actually, nausea, vomiting is another significant thing, which is why we're worried about the recovery position and making sure their airway's clean. So contraindications, there's none. If it's life-threatening, they need it, done, they get it. There's no age limit, you're not worried about this stuff. It doesn't have any adverse side effects. And the reality is we can use it on little ones up to big ones and everything between. So don't necessarily get stuck in the, well, I'm not sure, he's only a child, did he get an opioid or not? Kids eat stuff. And you know, you move into a house with a previous drug lab in there, you have no idea what it is, and the little kid gets into something. Or grandma leaves her meds on the counter, and, oh, what's this? M&Ms. It happens. We see it frequently. So again, going back to don't assume things. Kids and people are different. They get into things whether they want to or not. So don't be afraid. Give them the NarCan if you think they need it. And if you give it and you don't need it, no big deal. If you give it and the NarCan doesn't do anything to improve them, It could be something completely unrelated to opioids. So don't even, now if you happen to have another one, you could try it and see. But don't get bogged down and say, oh, I shouldn't give NarCan. Give it. If when in doubt, just give it. So we're going to go over some administration and talk about some of the different topics, or sorry, different administration routes that they have. So the NarCan Injection Kit, this is typically more on the medic side. There are some pharmacies that have been prescribing this as well. The problem with this is you need to clean the vial, inject, draw out the med, clean the site, inject, push the medication. Or you start an IV site, so again, you're cleaning the site. There's a lot more stuff to this. It's great in the fact that it gets around some of the more expensive kits that are out there. So sometimes you see them out in the public. I've seen, I'm trying to remember what state actually gives some of these out. I don't remember if it's like, I don't know. Some states actually have this versus some of the other ones I'm going to show you, but this may be a kit you see. So this is a 0.4 milligram per cc in 10 cc's. So that means that there's 4 milligrams in 10 cc's. So there's a lot of liquid and a good dose of medications. Again, time consuming to know how to give an injection, know how to start an IV, whatever it is. You can go in the leg, you can go large muscle mass, so you don't have to be completely accurate, but it's more training and specialized than some of the other kits you're going to see. Atomized nasal NarCan is another variant. This is meant to go up the nose. Again, going to any mucous membrane. So this is going to be 2 milligram per 2 cc's. So there's 2 cc's of fluid, 2 milligrams total in 2 cc's. So what you do after you assemble, which I'll show you the steps on this, it's a little bit more complicated, more time consuming. So the way I'd best describe this is take off the colored caps. So there's a yellow, yellow, red. So you want to pop the caps off. You're going to insert the glass vial into the lure lock. Actually, before you do that, you actually want to attach the atomizer. So if you happen to squirt it, it's not a big deal. So the atomizer is this white tip here. You're going to attach that onto the end of the lure lock. So attach that to the end of that piece. You're going to screw the glass vial into this end, and there's a needle inside that punctures the plunger and makes the medication available to come out. The issue with, or not the issue with this is one of the kits that was more commonly dispersed to the public. The thing I found utilizing this method is there's a lot of volume and you're putting up the nose. So it's kind of hard. So what you want to do when you insert it, actually there we go. When you're going to insert it, you want to pinch off the other side of the nose, go up this nose and push hard. And you want to give half the vial and then pinch off the other side of the nose and go another half. So the entire dose up 2 different nostrils. A lot of things happen when people go unresponsive. The person sitting at the table is down forward. If they hit the counter, they could have a bloody nose. So now what do we do? Ooh, well, squirting liquid into blood isn't going to absorb. We want to hit that mucous membrane. So you can squeeze it in their cheek or any other kind of mucous membrane you can find. There's another one that's a little more sensitive, but we won't go there. But you squirting liquid into blood is not going to do anything for the patient. They need that, membrane contacted. So a lot of volume. It tends to squirt down the other cheek. It makes a little bit of mess that kind of goes everywhere. The thing to remember with the atomizer on this is when you're pushing this plunger in, it comes out that end, and it's meant to essentially atomize it and mist it. If you push it slow, it tends to give too big of droplets and it doesn't really absorb well, so you kind of have to push it hard and fast and stop roughly halfway. It's hard to stop exactly at 1 milligram or 1 cc. So if you go 1.1 or 1.2 and whatever, that's fine, but people tend not to push as hard with that, and it doesn't atomize as much as it should, and then it just comes out. But regardless, there's still a lot of fluid that we're talking about here. Again, not recommending one or the other, but you're seeing a change in the times. These kits have come out 4 milligrams and 0.1 cc. So we're talking about one had 2 milligrams and 2 cc's. This one's got 4 milligrams and 0.1 cc. So we're talking very, very small amount of liquid. These kits, actually they have trainers here. Essentially they come out in a blister pack. You peel them out, come up the nose, insert into the nose, and just push. And this essentially is a little vial in here, so your push is going to be there and done. That's it. It squirts out just a tiny little bit of liquid with 4 milligrams. So if you have somebody with a bloody nose, it's really important you get this as clean as possible, or find somewhere, even in the mouth, whatever you need to do. But a lot less liquid to go elsewhere, and double the dose of that. What would have gotten you 4 cc's of fluid, you're doing in 0.1. So a lot less fluid for 4 milligrams versus 2. These packets are available as well. Again, you're going to peel, place, and press. It's very simple, very fast. There's no assembly. There's no fumbling with stuff. It's kind of nice that in that context. The auto injector is kind of a cool piece of equipment, but it's expensive. They're great. They're essentially automated, so you pull them out of this outer packet. So this inner medication delivery device actually inside this. As you pull it out, it'll actually start talking you through things. It'll say, if this is an emergency, pull the red arming tab. So you're going to pull it out of the packet. You're going to pull this out of this container, the outer shell. It's going to start the unit's going to start talking to you. It'll say, if this is an emergency, pull the red base off, the safety guard. What you're going to do is put it up into a large muscle mass. Thigh is a great muscle mass. You don't have to worry about nerves, stuff like that, as much as you would somewhere else. And you're going to inject, hold for 5 to 10 seconds, and remove it. So they're great. They're automated. They talk you through it, but they're very, very expensive. They fold very nicely. They're very small. Like, they're thin. They could get tucked away in lots of different spots, but the cost is there. I tend to like this a little bit more, and one fact is we're going back to the IM injections, the intramuscular injection. It's fast, it's efficient, it's done. So if you happen to smash your nose or something along that line, you're not worried about getting that medication is going in, it's going to your muscle. The absorption rate's a little bit different in muscle versus mucous membrane, but it goes in regardless of blood. If you ever stumble across these or EpiPens, so the EpiPen auto injectors for allergies, do me a favor, if you ever see me get stung by bees, when you stab me, be careful, because with cargo pants, what's right here? Wallet. That's right. You put that EpiPen or that injector into my wallet, you have to replace my credit cards with the pinhole, but the fact is the medication's in my wallet, not where in my body. So be very careful with people's pockets, empty it, remove it. Honestly, my preference is take the pants down, see what you're dealing with. I want to see what I'm working on, so regardless of patients, whether you're doing CPR, exposed to the chest, if you're doing injection, I want to see skin. That way I know I'm not stabbing keys, wallet, purse, whatever, or whatever's in your pocket. Like, I want to make sure you're getting the most bang for the buck. Originally you started at 0.4 milligrams, and now the newer versions that I'm seeing released are 2 milligrams. So there's even a change in the way the medications are being rolled. They're a little bit stronger. When I first started giving NarCan, again, you're looking at 2 to 6 milligrams tops. You're seeing 10, 15. Again, going back to the synthetics and the strength of stuff, it's just we tend to use more. So again, they're kind of cool because they talk to you. They're kind of annoying to train through because they will prompt you through things, but they're very easy to pull them out, but they're expensive. So again, going to cost, is there a difference? I don't really think so. It's finding out what people need. One of the things that I came across a couple years ago, my previous job was medication and getting access to NarCan. We had a 90% saturation of health insurance in the area, and we actually pulled data from one pharmacy, so a big pharmacy in the region, and just pulled data, didn't pull names, didn't pull anything else, and said, I want to know what kind of kits people are buying. I want to know if they're buying the expensive one, the syringe style, whatever it is. We found out that even with a high percentage of insurance, almost 80% of people are buying it cash. Well, why am I getting a prescription and paying cash if I have insurance? Stigma? So I am a very big proponent of supporting whatever people need. We're worried about stigma. If I go in as a firefighter and buy NarCan in a small town, guess what? And the other thing too is it does technically go on your medical history. So when doctors prescribing, they will see, not necessarily a flag, but it'll say you have a history of NarCan. Why? Was it I'm good and I just want to carry it around? Do I need it for my, what do I need it for? But the problem is we start talking about stigma and bad or good, but the doctor's already automatically thinking you're getting NarCan. Why? And sometimes it might be, doc, my niece and nephew comes over all the time and I'm worried about back pain. I have meds in there. I don't want them getting it or whatever. But the reality is they're human. They need to fix the years of prescribing issues that have happened, unfortunately. And sometimes you're going to get providers that are nervous and say, I don't really feel comfortable prescribing this because you have NarCan, even though you just carried it to help people. I don't care why people carry NarCan. If I happen to see it in your bag, I don't care. You could be prepared, you could be a pocket. I treat this as a pocket mask. You're just prepared to do something and help out. Whether it's for you, for a loved one, for a stranger, don't care. So really, getting out of the stigma is kind of hard to do. But you see a lot of people paying cash for something that should be is covered on your insurance. It's cheap, but they're paying extra just to be anonymous. Here's my contact information. On behalf of the Pioneer Valley Planning Commission and the Medical Reserve Corps, I appreciate the time of you guys coming out. Again, I know this area's been hit very, very hard with opioids coming from New York, or honestly coming from New York, but 91 corridors right here. We all know which way traffic goes. And coming in through New Hampshire, stuff like that, it's really devastating New England. It's a hard thing. Certain parts of the country are not being touched by this nearly as much, and some are actually not even dealing with this at all, which is kind of surprising. But there's a lot of substances that are out there, and people dealing with lots of different issues, and we're looking at supporting them however we can, because it turns out it's going to be someone's loved one. It's somebody you know, somebody you care about, and the reality is these people are somebody's brother, sister, mom, dad, whatever it is. So take care of them. So thank you very much. If you have no other questions, I appreciate your time.
Thanks, Chris.
Thank you.